Good evening, everybody. Thank you for joining this hour. This is the April chapter of Therapeutic Forum, Sri Lanka College of Internal Medicine. So, this therapeutic forum was initiated to enhance the knowledge and practices among the practicing physicians through subspecialties as well as the experts in each and every field. Without further ado, let me invite Dr. Nishant Jayasekara, President, Sri Lanka College of Internal Medicine, to address the gathering. Over to you, sir.
Thank you very much, Ranga. Now, stroke, of course, remains one of the leading causes of disability and death worldwide. As physicians, regardless of specialty, our role in the stroke care pathway is critical, from early recognition, diagnosis, acute management, and rehabilitation. Thank you for joining us for today's important and timely webinar themed Stroke at the Crossroads, Medical Precision and Surgical Decisions. I especially thank Dr. Sanjeewa Garusinghe, consultant neurosurgeon in NHSL, with a deep commitment to improving outcomes for stroke patients through timely intervention, multidisciplinary collaborations, and evidence-based approach. In this session today, we will explore the evolving responsibilities of physicians across the care continuum, highlighting current best practices and discuss the latest advancement in stroke interventions, including surgical and non-surgical approaches. We will also take a closer look at how we as healthcare providers can better coordinate to ensure rapid response and patient-centered care. So without further ado, may I invite Dr. Ranga Gunasekara, the moderator, to introduce the speaker today and proceed with the webinar. Over to you, Ranga.
Thank you. So let me introduce the speaker today, Dr. Sanjeewa Garusinghe, MBBS, MS, MRCS, consultant neurosurgeon for neurotrauma unit, National Hospital of Sri Lanka. And he has been a consultant neurosurgeon for past 12 years. And I have asked for a lengthy CV from him, but he said that just my name and the degrees is enough. So over to you, Dr. Garusinghe.
Thank you. Thank you, Ranga, and thank you, Dr. Krishanta, giving me the opportunity to talk to you all and share my experience about this stroke care. And I mean, it's a good chance for neurosurgeons to speak to physicians who see these patients first before they come to us. So let's start from the beginning. So medical precision and surgical decision, stroke at the crossroads. So when you talk about these strokes, and obviously your patient, when they come to you, they don't come and tell you, okay, I got a stroke or I got infarction. So in neurosurgical point of view, the symptoms are acute severe headache with some neurological manifestations. There are a lot of differential diagnosis for this kind of behavior, the presentation, but for us, the most important things are bleeding. Number one is subarachnoid ruptured aneurysm, and number two is ICH, IVH, and then MC infractions, and some other rare, but they are neurosurgical causes like tumor bleeding, sometimes the obstructive hydrocephalus, and sometimes the IIH or idiopathic intracranial hypertension, and the pituitary apoplexy, Chiari malformation, trigeminal. All these things can present in the middle of the night with acute severe headache or pain and some other neurological signs and symptoms. So let's see what are the signs and symptoms we are worried about in this condition. Now, some of the, I mean, the important thing is when you take the histories, the headache, if they presented, how bad is a headache? Thunderclap headache, the worst headache I have in my life. And it's very important. I mean, if you have that kind of symptom, you think about, okay, this patient got a subarachnoid hemorrhage or intracerebral hematoma, and if even the headache, just ask about whether you have past similar episodes, because there are some neurosurgical causes which can recur. For example, colitis, tumors, even the trigeminal neuralgia, and associated neurological symptoms like seizures. If you have seizures and headache and paralysis, you think about brain bleeding or ruptured AVM or tumor bleeding, and sometimes the sensory deficit in the both hands with severe headache. There may be a carry malformation and behavioral changes common in SDH and frontal lobe tumors. And the syndromic patients, I mean, there are a few neurosurgical causes can come with syndromes like Cushing syndrome, acromegaly. They can have pituitary apoplexy, but if you know that your patient has a polycystic kidney disease, think about ruptured berry aneurysm if they come with uh, acute severe headache or low Glasgow coma level. And your patient complain coughing, sneezing, headache, think about carry, and obviously vision when you talk about the raised intracranial pressure in IIH. So one of the important thing, if your patient has a past history of PP shunt done or any neurosurgical procedure, especially if you have a patient with shunt, you come to your A&E with collapse, always think about before the stroke, think about block shunt. That can happen. When the blood shunts may not be evident from the CT sometime because CT might take some time to develop the ventriculomegaly. But if they come with headache, loss, unconscious, think about shunt plug. And past neurosurgical procedures like past brain tumor and resection or taking blood clots out, SDH. And if your patient has primary known tumors like CA breast, CA lung, think about cerebral deposits or bleeding into tumors. Obviously, the risk factors for brain bleeding like hypertension, diabetes, hyperlipidemia should be considered. Examination, obviously, we should know about the Glasgow coma level. That is important when you communicate with your neurosurgical colleague, as well as if you make a decision whether to intubate or not. And prognostic point of view, if you know that your patient is GCS3, I mean, we know the prognosis is not very good. Whereas GCS 12 to 14, like they have some mild conditions, so we need to attend fairly soon. Similarly, GCS 9 to 12, intermediate group, again, you need to resuscitate them promptly before we do the definitive assessment. So neurological deficits, detailed neurological examination. If you have time, look at the fundus, look for papilledema, and sometimes the retinal bleeding, retinal hemorrhages, and subarachnoid can be diagnosed. Syndromic features like neurocutaneous manifestations, blood pressure, obviously. And so if you have patient with this presentation, acute severe headache with some neurological manifestation, the first line investigation is do non-contrast CT brain. That is the investigation. Don't think about MRI because there are a lot of advantages of doing non-contrast CT brain since we are looking for blood or the blood or blood products. In acute setup, if you do CT scan, especially in subarachnoid, if you do it in 6 hours, its sensitivity goes more than 96%. Sometimes some series it says about 100%. And but if it delay like the symptoms and the time of doing CT delay, say for 24 hours, then the sensitivity drops to 80% because with the CSF the blood can wash out with the normal CSF pathway. And the non-contrast CT is freely available almost all hospitals in our country, the base hospitals, and it's very fast. And other than the blood, you can see the edema, midline shift, hydrocephalus, or the infarcts. And since there are no contrast involved, you can do it in the middle of the night. But keep in mind, if you clinically suspect your patient got some arachnoid, for example, neck stiffness, severe headache, and keep them fasting so that if you see blood in non-contrast CT, and then you can order a CT angiogram at the same time. You don't want to take the patient back to your ward at the same setting in the radiology department. You tell that your patient is fasting. You can give some, if there's any allergies, give some hydrocortisone or some other emergency prophylactic for allergies, and do the CT angiogram, because we need to look at the vasculature of the brain. So again and again, no MRI in acute setup. So if you see if your patients the CT scan is negative, and when you order this non-contrast CT, there's a particular way of ordering non-contrast CT. You must order non-contrast CT thin cuts at the skull base. That means 1 millimeter cuts at the skull base, and always ask for a sagittal, axial, and coronal cuts. So only sagittal might miss the blood. So the coronal cuts are very important, and you have to mention the thin 1 millimeter cuts at the skull base. So if the CT scan is negative, then you have to go for a lumbar puncture. But remember, lumbar puncture takes some time to produce hemoglobin breakdown products like bilirubin. It takes about 8 hours to get the positive results. And if a CT scan is positive for subarachnoid, then the next line investigation is CT angiogram, plus or minus DSA. So if I think in medical department, do the CT scan and see blood, and then it's, I think it's neurosurgeon's call. I'm sorry, I'm just talking. I mean, Ranga, I think I'm sure you can stop me at any time, you and the other colleagues,
Yeah.
whoever who listening. And I'm sorry if I'm too fast. Please tell me.
No, that's all right. Go ahead. Yeah.
Right. So positive CT scan, that means subarachnoid blood. Then you go for angiogram, and then the DSA. So leave the DSA and angiogram for us. I think if the first CT scan is positive, then you should I think discuss with the neurosurgical team. Then you can send the patient across to neurosurgical department. But until the patient is accepted, there are certain things for emergency department to do in brain bleeding, whether it's aneurysmal bleeding, whether it's ruptured AVM, ruptured aneurysm, or the intracerebral hematomas. There are things that the most important thing is, in case of aneurysm, to prevent the rebleeding, and the treat if there's hydrocephalus developing, to treat that, and treatment of vasospasm, and avoid metabolic derangement. So in your department, I think you should keep the patient in a dark, non-disturbance, shady area. Even the lights and disturbance can make a re-rupture of aneurysm. So the aneurysms, the chances of re-rupture is 80% in for 24 hours, and it declines over the period of time. The re-rupture, the second rupture, carries high mortality than the second. So our target is to protect the aneurysm, and the treatment of vasospasm is include you give adequate fluid. I think those days they talk about 3 liters of fluid and talking about the triple H therapy. Even now it comes in different words. You give adequate fluid and resuscitation, and correct any metabolic derangement, especially sodium and calcium derangements. And blood pressure is very important, because, as you know, the cerebral perfusion pressure is mean arterial pressure minus ICP. So when you have subarachnoid, or when you have ICH in the brain, the normal brain autoregulation will not be operated. So all your brain perfusion depends on your blood pressure. At the same time, if you shoot up the blood pressure, there's a risk of the aneurysm rupture. So keep the blood pressure about 140. And if your patient is TCS of 12 or less, before you take the patient to angiogram, you must resuscitate the patient. So these are some of the measures. I think by looking at the the non-contrast CT, the pattern of bleeding, if you look at the first image, the blood is more towards the left side and the anterior. So it's most probably anterior communicating or middle cerebral artery. And in the second one, you see the equal distribution of blood. So it's probably midline aneurysm, like again, ACOM or basilar tip aneurysm. But little more in this side, maybe MC involvement. But in this case, third case, it's obviously still in Fisher blood, most likely a middle cerebral or MCA rupture. So if your patient is on antiplatelet, you'll have to stop that. Starting anti-epileptic, there's no proven benefits or evidence based to start anti-epileptic prophylactically in subarachnoid. But if your patient presented with seizures, then of course therapeutically you can start. And there's no place for a tranexamic acid in subarachnoids. Maybe no mannitol, and 3% may be started if the sodium is low and if you see severe cerebral edema, as in this second case. Nimodipine, 60 milligrams 6 hourly was the dose given in nimodipine trial. So the nimodipine is a calcium channel blocker, and believe that it dilates the vessels by blocking the smooth muscle vasculature. But more than that, it has some intracellular effect on brain cells, like intracellular calcium channel blockage, and then it reduces the oxygen demand to the brain cells, and that will prevent the ischemia or the delayed neurological deficits happening. So then if you look at this overall subarachnoid outcome, and we have the two grading system. We commonly use this WFMS grading, World Federation of Neurological Societies grading system, and Hunt and Hess, and there's another Fisher grading for radiological CT grading system. So if you look at here, even the best grade, like grade 1, the survival is 70%. And mind you, this is only a survival. This doesn't tell about any neurological deficit, so say hemiparesis or confusion, but this is just survival. And if you have very bad presentation onset, like GCS of 3, they just 1 year survival is about 10%. So so aneurysm is kind of the intervention of the coiling or clipping, which we are going to discuss in next few slides, is again prophylactic procedure because it doesn't treat the ruptured aneurysm. It prevents only the second rupture. It's amine coiling, it's amine clipping. So if you have aneurysm, the subarachnoid positive, you are going to do a CT or DSA. DSA, few words. I mean, DSA, you need to have interventional radiologist, and not all the aneurysms we do DSAs, especially MC aneurysms, lateral aneurysms. We don't ask for DSA. We can clip without DSA. And DSA again, it's an invasive procedure, and there's a procedure related risk of rupturing aneurysm because they pass the catheter up to the circle of Willis and then they inject a dye, and there is a pressure develop inside the vessel that can rupture the vessels. And when you do DSA, a neurosurgeon on call should be on board because if that rupture, then he has to attend for that. And if you do DSA, in developed settings, what they do is they just do a diagnostic DSA. If they find aneurysm, they do, then they are coiling. But that is not happen in our part because they give another date in others' day. It's very unlikely for us to get the diagnostic DSA and the therapeutic coiling at the same time. So these are the nice guidelines we just discussed about if you have patient with suspected aneurysm, you do the non-contrast CT, and then if the CT is positive, then you go for a CT angiogram, and if there is aneurysm, then you advise discuss with the neurosurgical team. And if your CT is negative, and then if your lumbar puncture also negative, then you think about other causes for the similar presentation. And So when you treat the aneurysm, the clipping versus coiling, what do you like? I mean, you like clipping or you like coiling? I think obviously everybody like coiling because coiling is less invasive. It's like a stenting of say cardiac stenting, and the clipping like a bypass procedure. You have to open the brain and dissect the vessels, identify the aneurysm, and clip. There is a trial called ISAT trial. I mean, this is the trial which consider both clipping and coiling. It was a multicentric trial done in 2004 in Europe. So they divide the patients for early clipping or coiling, and there are a lot of kind of argument and discussions about the outcome of this ISAT trial. And ISAT trial suggested that the coiling is far more better. The 1 year mortality is reduced, and overall survival is better. So more and more aneurysms were directed towards the coiling, but later, with time, people identified because the ISAT trial done only for 2 years. They have only evidence for 2 years. But later, people identified the outcome, the shortage of coiling. So now they are working the kind of a management plan. If you have wide neck aneurysms, if your patient is young patient less than 50, and especially MC aneurysms, and if you have problem with navigating to the aneurysm, the passing the catheter to the aneurysm, then we suggest clipping of surgical clipping. Whereas the aneurysm neck to dome ratio is sac ratio is 1.3. That means the sac is small, sac is bigger and neck is small. And then we prefer them to them for a coiling. And high grade SH means your patient is kind of a low GCS, and sometimes the basilar tip aneurysms is special on rare locations, posterior circulation. And if the patient has a lot of vasospasm, then no, we ask for coiling. So not all the aneurysms good for coiling. Similarly, not all the aneurysms good for clipping as well, but clipping still is the gold standard for aneurysm. So if you look at this image now, clipping is gold standard, and actually the biggest problem with the coiling, why the coiling is not suggested for younger population less than 50, the annual recurrence rate is about 2-3%. So because young patients live longer even after coiling, so they tend to get recanalization of the aneurysm as in this case. And so you see the coil here, coil has come out and aneurysm has recanalized. So in fact, actually a week before I had 2 weeks before I had to clip aneurysm, which had already been coiled about 2 years before young patient. So the coiling can have this that kind of a drawback. And if you talk about the cost for coiling and clipping, coiling, the coils and the guide wires are very expensive. Whereas the clipping is a surgical procedure, it's another surgery for a trained neurosurgeon. Right. So next bleeding point is, I think, intracerebral hematoma. In this slides, I think I have pointed out all the possible hematomas can happen. This is amyloid angiopathy, brainstem hemorrhage, hypertensive hemorrhage, again hypertensive, and intraventricular hemorrhage, and large lobe hematomas. So let's see how we're going to do the ICH. So hypertensive hemorrhage, or the intracerebral hematomas due to hypertension, there is a peculiar pattern that they are centrally located and they are around the basal ganglia region. Actually, the pathophysiology is arterial microangiopathy at this operator level because of the long-standing hypertension, and that pressure affects the vessels especially the operator vessels to the thalamus and basal ganglia and the brainstem area, and they get their lose their vasculature and they become sclerotic and stiff. And the peri-arterial space is widened, which can be seen in MRIs. You will see microinfarct, microbleeds, we call lacunar infarctions, and enlargement of the virtuous Robinson space in basal ganglia. So these are the kind of location you get this hypertensive bleeding, and remember this can happen in brainstem as well, because the brainstem hemorrhage is due to the hypertension. So when you have systemic hypertension, you have these sclerotic vessels. These vessels are no longer under autonomic or what is it called autoregulation, because the vessel smooth muscles are not working. So the systemic blood pressure can directly to some level or to some degree can project to your in arteries at this point and start microbleeding with the microtic aneurysms, rupturing of the microtic aneurysm and bleeding. So that's how you get this hypertensive bleeding. So that's a pathophysiology. And then the next one, next kind of bleeding, you will see the amyloid angiopathy, and that happened in periphery. Look at here, all these amyloid angiopathies are periphery, and this is common in elderly people. And not like a hypertensive angiopathy, this can happen again and again. And these are the group of people, patients who can be benefited or treated with surgical evacuation of clots. So in ICH general management, if you have a patient with deep-seated ICH or lobe ICH, there are certain management guidelines. I will start with the bottom one. Avoid, do not attempt resuscitation at first. So that is the first thing sometimes we do when you see ICH. Okay, we said, okay, let's keep him in the corner and we're not going to support and let him go peacefully. But that's not the way, because if you look at the actual, their brain is normal. What happened is there is a blood clot, foreign blood clot to its own blood clot has come to the brain and causing pressure on the brain matter. So it's try to resuscitate them and look for their, I mean, if you can get the ICP measurements, you can pass ventricular catheter, you can pass the brain probe, which is available in most of the neurosurgical department in our country. You can measure the pressure and keep the ICP less than 100, but less than 20. And the blood pressure has to be lowered, and the recommended one is less than 140. And since they are bedbound or paralyzed, think about the DVT prophylaxis, especially the graduated pneumatic device pressure devices, not the stockings most of the time, and keep them nil by mouth most of the time. Think about the aspiration risk. Do the Solovin assessment as early as possible. Treat the sepsis, and anti-epileptic, again, there's no routine usage. And if your patient had been on warfarin, think about reversing the clot, the vitamin K effects by giving appropriate fresh portion plasma or prothrombin complex. I think the trade name is Beneflex, which is available freely in the UK. And in our country, I think we give FFP. And the problem comes when you have this novel anticoagulant or antiplatelet agents with a lot of tongue twisting names, which I'm not very familiar. But I mean, if you know the antidote, please consider antidote as soon as possible if your patient had been on this agent. But one of the good things is these novel antiplatelet agents, and they are very short acting. But if you don't know the antidote, consider giving FFP or the prothrombin complex as early as possible. And always, if you have hematologists on board, please contact them as well. So antiplatelet and the PASH trial, there's a trial done. If your patient is on antiplatelet, aspirin, clopidogrel, commonly this one. If you give platelet, the outcome is not that good. So don't think about the giving platelet if your patient is on antiplatelet. And the effect of tranexamic acid, there are conflicting evidence. Some studies say, okay, tranexamic acid is good, 3 doses starting within first 6 hours, but some says not, I mean, awaiting better results. So, what is the role of neurosurgery in suspected or diagnosed brain bleeding? So, if you have, now as I told before, I mean, your brain is normal. The problem is you have this red color clot pointing inside the brain, so that exerts the pressure on the surrounding area. So the basic concept of doing the neurosurgery, the preserve this salvageable brain tissue, which shown in yellow color and the green color. This is called ischemic penumbra, and when you remove this clot as early as possible, then there won't be dead brain tissue surrounding the clot. So the neurology will be improved. So that is the basic kind of a principle of getting blood clot removal in ICH patients. So if you can remember this kind of a Monroe-Kelly doctrine and autoregulation ICP principles, so if you have blood clot in your brain, then what happens is your ICP goes up. In this Monroe-Kelly doctrine, it says if the volume in this closed compartment is constant, volume and pressure are in equilibrium in a constant level. So if one component goes up, for example, large hematoma, the other component should go down from this closed system to maintain the pressure. If that is what we call the Corning-Hall herniation. So again, in intracranial pressure and the intracranial pressure and the volume, if the volume goes up, the pressure at this point exponentially goes up. It can maintain up to this level, to a certain level, by adjusting, moving the CSF and the venous blood away from the brain. But the moment that threshold pass, slight increase in volume can exponentially increase the intracellular pressure. So again, cerebral blood flow and mean arterial pressure, as you know, even with these up to this change, the normal autoregulation works. Hypertensive patients, it has been reset towards the right side, but normal people like patients like this. But in ischemia or any cerebral insult, your cerebral blood flow is like this. It's directly proportionate to your mean arterial blood pressure. So this is what we do, and we do the clot removal. We do the clot removal at the same time we can remove the decompressive craniectomy. So then we remove the pressure in this closed system, closed skull, so the brain can relax and get its perfusion better, and will not go into ischemia and avoid ischemia and preserve brain cells. So this is what we are going. That's what we expect. So there are different ways of doing craniectomies. We do the small craniectomy, so we can do refined craniectomy. This is how it looks like when you open the brain. And this is the dura, this is bone flap, and this is the decompressive craniectomy, normal craniectomy markings. And the most important thing we need to understand is the surgery itself carries a risk. You have to anesthetize the patient. They are not the best patients, like they have the ischemic heart disease and other medical issues like hypertension, diabetes, all these medical issues. And on top of that, we are subjecting them for a major operation. So think about that as well. So what are the evidences for early surgery? So the cerebellar or the posterior fossa hemorrhage, there's no discussion. The posterior fossa has to be decompressed if there is a developing pressure onto the brainstem, or mainly the brainstem, but cerebellar involvement, cerebral edema. At the same time, if you have the blood clot infraction at this point, at this posterior fossa, obviously you will have proximal hydrocephalus or ventricular megaly. For that, you have to ask for a ventricular drainage or EVD. And the supratentorial hemorrhage has been discussed over the last many years. Stitch trial was the popular trial done in UK, multicentric trial. There are two trials, Stitch 1 and Stitch 2. cells, supratentorial intracerebral hematoma trial. Stage 1 trial was actually this was done in the center I was trained in Newcastle, United Kingdom. We were part of this stage 1, and when we recruited the National Hospital Colombo, I did few operations for stage 1, and but stage 1 was inconclusive because that includes the intraventricular hemorrhage. Then they developed this stage 2 trial without ventricular extension. They talk about the lobar hematomas, superficial lobar hematomas, and the stage 2 trial says if it is a lobar hematoma, it is less than 1 centimeter from the cortex, and there's no interventricular extension, and GCS is 9 to 12. So this is very important. So if your patient has a lobar hematoma and if his GCS is 13 or 14, we are not going to operate. And if your patient has lobar hematoma, if the patient is GCS is less than 8 or 9, then there's no point in doing. The in-between group, the middle group, are the group who will have some benefit if you do the early evacuation of blood clots, preferably within 8 hours. But even within 24 hours, if you do, the long-term survival is better. And think about the midline shift and LCP rising, and then you consider doing hematoma surgery. So in this context, you can remember the hypertensive bleeding or the very kind of a periventricular, basal ganglial central hematomas are not considered in this stage 2 trial because the centrally located hypertensive bleedings are not treated with surgery, because going to that point make more neuronal damage or brain damage than you take lobar hematomas. And the post-surgical or the best medical care in this hematoma patient. So we should avoid the antiplatelet in acute setting. But if your patient has a concurrent SSS thrombosis or venous thrombosis, then you will have to consider starting antiplatelet or offering. You always take the risk and benefits. So if you have to restart the antiplatelet for your patient, so your patient has a cardiac problem, your patient has ischemic stroke, and you need to start the antiplatelet, you think about the risk and benefits of starting antiplatelet. For example, if you have the bleeding, rebleeding risk is about 2 to 3% in centrally located hematomas. But hypertension, if you continue to have hypertension, that can increase by 4-fold. And amyloid angiopathy, you have 1 in 5 patient can rebleed again during first year. Rupture of AVM, again you have 18%. And if your patient is on vitamin K antagonist, the chances of rebleeding increases by 5-fold. So if you think about this, when you have to restart your patient with antiplatelets or warfarin again. So there's no so far non-randomized control trials done to restart antithrombotic in patients with intracerebral hematoma, because you can't randomize two groups to, okay, this group is going to be started with antiplatelet, or this group is not going to be started. So there's no evidence. So what they suggest is, if your patient has ICH, then always try to avoid anticoagulation in lobar hemorrhage, because lobar hematomas are the one which can recur. And if you but if your patient at the same time, if he has a high risk of thrombotic event, like for example atrial fibrillation, then think about restarting, because the cardiac risk is high. And if your patient is again high risk of atrial fibrillation, valvular heart disease, and you can restart even early, but you take the risk and restart with the known risk of or acceptable risk of rebleeding into the brain. And antiplatelet should be avoided in amyloid angiopathy patients and patients with uncontrolled hypertension. So This is from the restart trial done in interthrombotic randomized trial, only in UK hospitals. And they mention consider about the other methods, some atrial appendage occlusion, especially to prevent strokes, the atrial fibrillations. Other than you start the antiplatelet, you think about doing some surgical procedure, one-off procedure, and that's it. And these novel antiplatelet agents like apexibam and other agents, there's no evidence, but there is an ongoing trial, Apache AF trial, and we are expecting results. In overall, if your patient has intracellular hematoma, but if you have to restart the antiplatelet, there's no optimum typing or optimum dose to restart. But some observational studies suggest that you can avoid antiplatelet, or you can restart antiplatelet even after 10 weeks later. It may be safe, but not to start in acute setup unless there is a high indicated. So next possible cause with acute severe headache other than the hemorrhage is malignant MC infractions. And as we know, I mean, this is most of the time it's medical management. You know, you do thrombolytic, and if possible, you do the EDS and do the clot retrieval. And as a neurosurgeon, we have a place we do think about this decompressive craniectomy. There are 3 trials: Decimal, Destiny, and Hamlet trials, which is done in multicentric studies, and all these 3 studies, the conclusion was the decompressive craniectomy is recommended in non-dominant side. That means right side, because 90% of people have the left dominant, even the left-handed have the 90% chance of dominance in the left side. So we don't do the left side decompressive craniectomy, because if you did the left side decompressive craniectomy in left hemispheric infraction, you will have a patient who will not talk and understand the pain, or you just have a person without any cognitive value. So non-dominant hemisphere, young patients less than 60, and if you can manage to get that done within 48 hours, you can consider doing decompressive craniectomy in malignant MC infractions. So if you do the craniectomy, the advantage is one in survival is better than medical management. But if you talk about the disability, they talk about this modified Rankin scale disability, then there's no, I mean, the significant difference, because the group has only 1 score. The medical arm has 3, whereas the surgical arm has 4. So it only increases the overall survival. But again, the principle is same as in intracerebral ICH. You open the door in skull, so let the brain relax and avoid ischemic damage. Okay, so we have a case now, and there is a patient who's a 37-year-old female with acute severe headache, and she had a brief loss of conscious level, and she can recollect, and actually the family said that there was a similar episode in past, but one of his close family member suffered dengue fever very recently, and her conscious level was 14, no spontaneous eye opening only, but she's sleeping, drowsy, but when you can wake her up, and no other neurological deficits. Her blood pressure is 140. So what are the probable diagnoses? Anybody out of this list? Is it subarachnoid? Is it IVH? Malignant infarct? Bleeding into tumor? Any other these things? Any ideas? Well, I mean, if you go back to basic, and we'll have to go for an investigation.
We have muted the participants.
Apart from ours, I'm sorry.
That's fine.
So,
Okay.
yeah. So we have this list of differential diagnoses, and So anything is possible out of the. So actually, this patient was treated in one of the government hospital, and she was a 37 mother of 3 kids, and so they ordered MRI. So this was the MRI brain, and as you see, you can see the ventricular megaly, and temporal loans are dilated. Obviously, there's a hydrocephalus, and there was a lesion. This is a colloid cyst. Her diagnosis was colloid cyst, and what happened next? This is the postmortem, and you have the colloid cyst, you have the brain, and patient collapsed while waiting for the report. So where we went wrong, and so if you have this symptom, again, I want to reiterate that the investigation of choice is non-contrast CT brain. It's not like MRI, it's quickly available, and the reports is available. I mean, any clinicians can see this and identify the hydrocephalus, and it takes only very many minutes time, whereas the MRI itself take about 1.5, say 40 minutes minimum. So this kind of thing can happen in emergency department. So this is acute hydrocephalus due to obstruction by the third ventricle with the colloid cyst. The simple treatment was passing a ventricular drainage, and I was called and I passed the drainage urgent EVD, but I couldn't save the life because we passed the golden hours. So other causes, not very common, pituitary apoplexy can present to your emergency department. It's like a stroke, and look for any syndromic features, even the galactorrhea and other history points. And it mimic subarachnoid or interventricular hemorrhage. You have the neck stiffness, you have the photophobia, you have the fever, and the conscious level is dropped. So if you do the MRI, again, the CT scan is a choice. You see the pituitary and any dot of blood, you can see. Always ask for sagittal axial coronal cuts of the CT scan and skull base thin slides. And this feature is very important. This is a fluid level in MRI because when you're doing the MRI, you seated supine, you have the fluid level. The same fluid level is seen in sagittal cut like this. So this can be managed medically most of the time. Earlier, this is urgent neurosurgical intervention recommended, indicated. But nowadays, it's best managed medically first few days, and when the edema and the bleeding settle, then we can take it. We can operate through the nose. So bleeding into the tumor can present to you as a stroke. And again, you do the non-contrast CT. You can see the bleeding on top of the tumor. So many pictures. And treatment is started steroid for tumor edema, because if you talk about the cerebral edema, the steroid has a role only in tumor-related edema, not in other type of cerebral edemas like cerebral edema due to any other cause, not treated with the steroid, but only the tumor-related edema. And consider anti-epileptic. And if these kind of patients have low platelet, less than 100,000, please consider transfusion, because red bleeding can happen. And you must refer to the neurosurgeons as early as possible. And this is a rare condition. I mean, it's not very rare. I mean, you can have acute severe onset headache. Sometimes they come with coughing, sneezing, burst headache. Sometimes they collapse because the tonsillar descent at the foramen of Monro. Your CSF, when you cough and sneeze, your intracranial pressure goes up. When the pressure goes up, the CSF temporarily goes down to your thecal sac to the spinal cord. But because of this compression at the foramen of Monro, foramen magnum, because of the tonsillar descent, the CSF can't go down. So you get an intractable headache, and sometimes they can collapse, and very rarely even the sudden death had been reported. So the surgery, the treatment is surgical. You do the posterior for decompression, and even you can see in the same case you have the syringe, and the syringe had improved even after the operation. So this is easily treatable, non kind of innocent condition. So trigeminal neuralgia, you can see rarely, not very common, but in acute emergency department, you will see not very commonly this ophthalmic division, but mainly the face and mandibular, maxillary and mandibular division. This is, as we all know, you treat with the carbamazepine and respond very well. I mean, if your patient does not respond to carbamazepine, the treatment of choice is microvascular decompression. There are other intervention like balloon decompression or phenol injection. There are other procedures, but this is the gold standard procedure. We do this procedure very commonly, and it's very straightforward now. You see the nerve, you see the vessels, and you just go to that point and add some Teflon material in between nerve and the vessel, because the nerve get compressed at this exit zone of exit, where you get the defective myelination, because inside the brain you get the myelination from the oligodendrocytes and other astrocytes. But when it comes to the periphery, when it exits, the Schwann cell take place. There is a bare area where the astrocyte to Schwann cell transit place. That is a place where your posterior superior cerebellar artery touching the nerve, and that triggers the pain. So it has a surgical management, and that's done. It's kind of a gold standard. You won't get the pain again. Okay, thank you. And this is all that we can discuss. I think I don't know if there is any provision for any questions and answers.
Yeah, Dr. Garusinghe, we have about 10 questions.
All right, okay.
Shall I start with the first one?
Of course, yeah.
When aneurysmal SH is diagnosed in medical wards, usually it is difficult to get them to undergo neurosurgical intervention, probably leading to increased mortality. Do you think this is safe for patients, and what can be done for the health system to improve this?
Yeah, I mean, this is a very good question. I mean, the if you look at this management of subarachnoid and protocol, I mean, the emergency department job is just to do an uncontrast CT and diagnose that. If your patient has an uncontrast CT scan positive blood in this around the circle of Willis region, as we shown in previous slides, it's neurosurgeon's call. I mean, in our hospital, we don't. I mean, very rarely we ask the medical team to do CT angio, because if you have any kind of a problem or getting because we have access to CT angios more easily than any other discipline. So what we do is we just do the CT angio, take to our ward, and if angio positive, we do the clipping or coiling, clipping in the next available list. But if need to be coiled, or if need to be if needs that DST to be done, then we'll have to refer to the DSA department next available, and get their DSA support and take it from there. Did I answer the question?
No, I think he's referring to the delays that are happening mostly in peripheries. Because when we conduct neurosurgical centers, sometimes the answer that we get it is we cannot take over. So sometimes something like that. He's asking how to improve the system.
Well, I mean, for example, I mean, neurosurgeons may refuse the patient if your patient has a subarachnoid hemorrhage, and if the patient has poor glaucoma, starting with WFNS grading poor grade, then even we do something. I mean, because we have to think about that. The aneurysm surgeries are prophylactic procedures. We are not going to treat the what rupture. We can't treat. I mean, what rupture, and then you treat for a, say, if there's a hydrocephalus or metabolic derangement, if there is a delayed ischemic event, then we have to treat. Most of them are medical or intensive care management, not the neurosurgical. But neurosurgical management is to prevent the second bleeding. So that concept has to be understood. And the next thing is if your patient is starting with the poor outcome, like low WFNS grading or Hunter-NS grading, and then it had to resuscitate the patient. I'm not telling that leaving the patient in medical department is correct, but that should not be the way. These are neurosurgical patients and should be handled by the neurosurgeons or similar department like neurology or neurosurgical department. But I think the problem happened in what you mentioned is because of most of the neurosurgical departments are overloaded, and the ICU facilities are not that uh, great. Even in our hospital, we don't have beds freely available for each and every low GCS patient with subarachnoid or intracerebral hematomas. So I think this is the problem. What you mentioned is because of the combination of if the patient is starting with a poor outcome, if the receiving end has no facility, and I mean the bottom of the line maybe some individual or uh, the surgeons or the receiving end choices also matter.
Right. Thank you.
Yeah.
So what are I think we have answered this question partly. What are the clinical features that neurosurgeon consider to decide on operating or conservative management of ICH patients?
Well, ICH, I mean that's depend on the STICH2 trial. That is the only trial available for ICH patient. So again, when you look at the ICH trial, uh, I think if you look at the picture, uh, and they're talking about this kind of amyloid angiopathy, the distance from cortex to bone skull to less than 1 centimeter. Actually, Stitch 1 trial, it was 2 centimeter, but the Stitch 2 trial, they narrow down to 1 centimeter because it's easily removed and surgical trauma is minimum. But the one of the common ICH we do have in hospitals. So this is the common ICH we see in hypertensive bleeding. In this kind of ICH, even though it extends up to the skull, but it involves a major part of the thalamus. These kind of patients will not be benefited by removing the clot because they are already the outcome is poor, and there's no evidence of doing this kind of ICH. And if you have the other group of patients like superficial lobe hematomas, like frontal lobe, occipital lobe, or the parietal lobe hematomas less than 1 centimeter from the cortex without interventricular extension. Because if you have ventricular extension, the prognosis, poor prognosis, the prognosis is not very good. And ventricular blood sometimes it's difficult for us to take. I mean, even you take the ventricular blood, they don't improve well, and even the GCS level. So if you have best GCS like 13, 14, 15, you don't operate, even though you have the blood clot. But if you have your GCS of very low, like less than 18 intubation, there's no point in doing. But I mean, and the delayed presentation like less than 8 hours. Sometimes the patient comes 24, 48 hours later. There's no point because we are talking about ischemic penumbra. We are talking about the salvaging this salvageable ischemic area. Because if you do not attempt, I mean, if you very early, there will be permanent damage happen to the brain cell. So even we remove the clot, that won't improve the neurology. But nevertheless, I mean, with these indications, I mean, since you asked this question, I want to tell. I mean, there are certain exceptions from individual neurosurgeons. For example, a couple of years ago, I had a physician who came with brain bleeding to exactly to the verbal Broca's area. So it was very small hematoma, and there were no midline shift, and it was slightly deeper to the cortex, involving the superior temporal gyrus, and and he was a clinician, and there was no much indication for me to do, but I did that early because I thought that, I mean, if I leave this, it slightly damage the verbal area and word generation centers, so it might affect his future. So like that, I mean, we should not be a part of the trials we should think, logically and do the best for our patients. So you take a chance and inform, always discuss with the family, tell the risk. If they accept, we think about doing that.
So the next question is, in the case discussed, was there any relevance to the history of dengue or was it distracted?
No, there were no relevance at all. It actually, that was a true case. There was a history of dengue fever, and that kind of directed to a different direction. That I think that made the reason clinicians ask about MRI or think about brain tumors or some other. But what the point I wanted to highlight is MRI is not the investigation in acute setup, because cholecyst, anything acute hydrocephalus, even the subarachnoid blood can be missed in MRI. So MRI should not be done, and it cannot be done even in the busy department like middle of the night. It takes next day, and reporting takes time, and procedure itself takes time. Actually, that's what I wanted to highlight.
What is the target sodium level in ICH, or what will be considered as the low sodium?
Well, the sodium, as you know, we categorize mild, moderate, severe hyponatremia. That's less than 135 to 30 is mild, then less than that to 20 are moderate, and less than 120 severe hyponatremia. So there are different articles. Some says to keep above 140. So in our practice, we keep 135 to 40. That's our target.
When do we start antiepileptics? Only if seizure present, and what antiepileptic to be used?
The antiepileptic in ICH, subarachnoid, any kind of hematoma, you start only if your patient presented with seizures. Then the choice of antiepileptic is drug of choice is levetiracetam, 500 milligram twice a daily, and you can go up to, I think, up to 3 grams a day. I think, yeah, 3 grams, and then that is for treatment dose. That is for if your patient presented with fits, and that you can continue the evidence about 2 months. Beyond that, there is no proven benefits again. Then you tail off the drugs and see whether he gets fits again. Then it's a matter of treating the epilepsy. It's a different discussion. But there's no indication for prophylactic antiepileptic. Only for therapeutic if your patient presented with, and again that for a short period.
If a dengue patient presented with an ICH, is there a place for neurosurgery?
So that's kind of a problem we face, and the problem is it's not any type of ICH what we discussed so far. So we were talking about the amyloid angiopathy, we were talking about the hypertensive bleeding, we were talking about the AVM or ruptured aneurysm or any type of ICHs. But this is purely because of low platelet and other increased vascular fragility and other vascular damage related to the viruses. So this, the problem we face as a neurosurgeon is when you have low platelet, doing the brain operation and operating and doing the craniotomy carries its risk itself of creating another bleed. But at the same time, you have a patient with expanding hematoma, which disturb the brain homeostasis and increase brain pressure, increase ICP, and so on. So we have to outweigh the risk and benefits. If the patient is safe to be operated, that is the first question we ask. For example, if he has the cardiac involvement with the dengue, myocardial suppression, the pleural effusion, saturation issues, and we cannot bring up his platelet by transfusing platelet and giving platelet again and again loaded. If that is create overloading problems, those are the problems we face, and then we may not. And again, the surgery is another trauma. It's a controlled trauma. We had to cut his skull and get the clot out, and The problem comes if you cannot achieve the hemostasis during the operation, when it's continuing to also bleed. Then what are you going to do? Are you going to give platelet again and again? Is he going to keep his platelet, or is he going to thrombolyze, distract his platelet because of the toxemic effect in the blood? So, I mean, I would think of why he developed, why he had brain bleeding. Was there any issue in delay in presentation, or failure in primary dengue care to go into that level? And then are we going to do the brain surgery on top of this, all these issues? Did I answer?
Yeah, I think so. Yeah. And what are the centers offer DSA with coiling in Sri Lanka?
Sorry, what are the?
What are the centers that offer DSA with coiling in Sri Lanka?
Well, I mean, the National Hospital, we have the, actually, the neurotrauma department has two dedicated DSA machines. And the National Hospital itself has another machine. So basically, we have three. And Kandy has one machine. Karapiti has one machine. And those are the centers as far as I know. And in National Hospital, there are neuro-interventional radiologists around the clock. So if you have cases, I mean, what you can do is you can speak to the on-call neuroradiologist and discuss with them and get a date, but not the aneurysm, but the routine procedures. Aneurysm is emergency, you have to transfer to a neurosurgical department. But if you're going for a DSA for a routine procedure, for example, AVM or other DSA, routine surveillance DSA for aneurysm like that, then you can discuss with them and they get the date and then transfer to our department, our wards, and we can facilitate that because as a principle, DSA patients, probably, and DSA patients should go through neurosurgical ward to the radiology department.
What would be the best way of treating cerebral edema, mannitol or hypertonic saline?
Well, I mean, that depend on the type of the cerebral edema. So if you talk about the cerebral edema, there are, I mean, cellular level, there are three types. I think the cytotoxic, vasogenic, and osmotic edemas. So if we have osmotic agents like 3% mannitol. At the same time, we have the steroid. So the evidence base, the steroid works only in vasogenic cerebral edema. You see vasogenic cerebral edema only in primary and secondary brain tumors. So if your patient has edema due to some other cause, especially in a trauma setup, you have the brain head injury, you get a severe cerebral edema, and there's no point in treating steroid for them. Then you talk about the osmotic effect of 3% or the mannitol. Then the matter of, the point is whether to start mannitol or the 3%. So in trauma setup, the trauma-related edema, then the more trend is towards the 3% saline rather than the mannitol because of the known problems with the mannitol. Because I mean, mannitol itself, it damages the blood-brain barrier. It takes the drag the fluids and increase blood rheology in the microvascular level, but at the same time, it partially damages the blood-brain barrier. So some of the mannitol, sorbitol, the molecules extravasate into the interstitial space. So you can have rebound cellular edema, and it can affect your blood cross matching and things. And if you have renal issues, kidney issues, you have problem with giving mannitol. So the saline, the 3% saline circumvent most of these problems. So you can freely use that 3%. But the important thing, when you do the saline, hypertonic saline, the dosing and infusion rate has to be very meticulously monitored because of the known side effects of pontine demyelination of giving sodium.
Yeah. Next one is we see many SH patients with negative CTA and DSA. Please explain.
Yeah, I mean, if you talk about the literature, about 90% of the subarachnoid, you have angiography positive, like either CT or DA. So about 10% of the stage, you don't find any vascular cause. So then there are other causes. For example, it may be bleeding from cavernomas, and the cavernomas are angiographically occulted. And sometimes even the drugs, toxins, for example, nowadays the caffeine, the amphetamines, and the ice, or the other substance abuse, they get the subarachnoid hemorrhage without any aneurysm or any vascular damage. And even the non this hematological deranged ones with low platelet or some malignancies can have the subarachnoid. So it's known thing about 90% of subarachnoids can have ruptured berry aneurysm, so can have the ruptured vascular lesions. But 10% they have other list of causes starting from these substances, blood disorders, all these things.
Is there any particular size of ICH which definitely need neurosurgical intervention?
Well, I mean, there is no such a size as far as, I mean, if you go with Stitch 2 trial, it says the lobar hematomas and with this GCS level and midline shift, all these things. And some says 50 cc. I mean, if you divide if you multiply the length, height, and width and divide by 2, then you get the volume. And that they consider some amount, but I mean, there's no particular level of, okay, this is say 20 is more than 20, you go, and there's nothing like that.
What is the threshold for this is a good question. What is the threshold for intubation in SH patients before we transfer this patient to a tertiary care for intervention to reduce the rebleed in trans procedure?
Well, I mean, if you think about how they rebleed, is the rebleed if you have uncontrolled hypertension. If the blood pressure control is the number one. So the intubation is why we intubate due to many reasons. One is to protect the airway, because if your patient cannot, you talk about the GCS of eye response, verbal response, and the motor response. If your motor response is, if they cannot localize the pain, if they cannot stick your tongue out, stick his tongue out when you ask to obey the commands, that means he cannot control his own tongue. So that means motor score is less than 5, then the cumulative score is less than 8. So that means he cannot control his own airway. So he can choke his airway himself by pulling his tongue back during the supine position and during the transfer. So such a patient definitely need to be intubated. And on top of that, if your patient is not GCS of 15, say 13, 12, but you have a long distance of transfer, and you are worried about patients during the transfer if something happens, and if the patient is vomiting, having froth, all these things, it's always safe to intubate and then send the patient across to the other receiving department.
Should you repeat the CT in all patients with capsular hematomas or only when there's a deterioration?
If they deteriorate. If they deteriorate, only we repeat the hematoma, especially lobar hematomas and the capsular hematomas. We do repeat C to see the expansion and developing hydrocephalus and for the prognostic value, and then we can make a decision as.
Is there a physiological reason for not using tranexamic acid in SH and maybe being used in ICH?
There is a clinical trial for tranexamic acid. I think it's crash trial for trauma and head injury and tranexamic acid. And the subarachnoid is, if you think about subarachnoid is due to the ruptured blood vessel aneurysm. And I mean, that has not proven, because when they come, the bleeding stopped, and the other risk factor of bleed is the non-risk factor is hypertension and agitation and all this kind of a disturbance to the patient. But giving tranexamic acid, there is no evidence to give tranexamic acid in subarachnoids.
Okay. In a patient with SH where their CTA and DSA is normal, uh, are there any further imaging that we can do?
Well, I mean, so we have patient with diagnosed subarachnoid and CTA is normal, then we go for DSA. If the DSA is normal, then we repeat the DSA after 3 weeks. That is a protocol because the first DSA can miss some of the small vessel aneurysms. The fact that because with the subarachnoid, the vessels can go into spasm. So vessels can go into spasm and narrow the vessel so that your dye will not go into the vessel and through the vessel to the small aneurysm. So I mean, we have false belief that this DSA is negative, but DSA is negative just because of the vessels. The small vessel doesn't carry the blood to the dye to the aneurysm. So give some time. Tell the patient even the two tests are negative doesn't mean that you are perfect. We can rule out your aneurysm. In our hospital, in our department centers, we do repeat DSA in 3 weeks to rule out any missed aneurysm.
Is there any time frame to start low molecular weight heparin for DVT prophylaxis after craniotomy?
Well, I mean that question there is no answer because again, I mean we cannot do randomized control clinical trials, so we cannot. I mean the craniotomies are different from each and every craniotomy. Craniotomy for aneurysm, craniotomy for tumors, craniotomy for some other fatty area malformation, all these things. But if your patient, I mean, what we do, what neurosurgical practice is, if your patient has a high risk of getting DVT, you give about say 2 3 days. We do about 2 hours or 2 days, and you will start with a half dose of low molecular weight heparin, and you can gradually increase to the maximum dose because especially the stroke patients. And we use the pneumatic, what is that, the pressure pumps even during the operation. All our neurosurgical patients during the craniotomies, we put them on pneumatic devices because the DVT happened during the operation. DVT start during the operation in the theater because that is the most prolonged operation we do. And the heparin, on the other hand, I mean the risk of bleeding. So we don't want to have brain bleeding in craniotomy patient. We give about say 24 to 48 hours if your patient has a high risk like obesity, non-breast cancer or malignancy, some kind of hematological issues, and all these cardiac issues with low cardiac failure, high risk of DVT. We start within 48 hours, some half dose of low molecular weight, and then gradually increases the dose.
What are the indications for EVD in a SH patient?
EVD is extraventricular drainage. EVD you do in, and if your patient develop hydrocephalus, if your patient is develop hydrocephalus and you radiologically see hydrocephalus and serial CT show ventriculomegaly, and then we go for the extraventricular drainage. But I mean, subarachnoids, more than the ventricular drainage, the easiest way is to pass a lumbar drainage. The lumbar drain can be done in ward setting under local anesthesia. But if you're going to put a external ventricular drainage, you'll have to make Burhole under general anesthesia. So what we do is most of the time when you do the operation for aneurysms, we always put them ventricular drainage and send to the ICU after the operation with a ventricular drainage.
What is the implication of IVH in a patient with ICH?
The IVH carries very poor prognosis. That is the reason because if you have lobar hematoma, which is purely lobar hematoma, the chances of survival is greater than if you have the same kind of lobar hematoma associated to ventricular extension. So I think if I could remember correctly, the mortality is increased by 50% if you have ventricular hemorrhage.
There's a question about a dipyridamole. I don't think that is related to the topic. It's asking why dipyridamole is not being used. I think this is beyond our topic.
Dipyridamole is something like aspirin. Is that correct?
Yeah. So
I think heard about that. I mean, it's kind of an old drug, but
Yeah.
I don't find any evidence. I mean, in literature with the dietary model. I'm sorry about that.
Well, I think we have finished all the questions that has been asked. There was another one. 5% dextrose in treating hypernatremia in a patient with intracranial bleeding, non-dehydrated patient whose GC is slow. Can we use 5% dextrose in treating
No, no,
hypernatremia?
no. We don't use dextrose in brain conditions because dextrose it can extravate in a disrupted blood-brain barrier, especially in our patients. I mean, the autoregulation is not working. Blood-brain barrier is disrupted. So whatever the sugar you give to the blood, intravascular volume can extravate into the blood and take a rebound the increase in cerebral edema in a delayed way. So we don't use.
Uh, I think this is, yeah. Are there any place for MRI in SH patient with CTA and DSA negative? I think this asking about the black butt MRI black butt protocol.
Yeah, MRI in SH. If I take it like this, I mean, not in acute setup. There's no. I mean, if you go to NICE guideline, uh, uh, NICE guideline says if you first diagnostic investigation and contrast CT head scan to be done as soon as possible, but negative CT head scan done within 6 hours of the symptoms onset and reported by a radiologist. So we did the CT and that was negative. And think about other diagnostics and seek advice from the specialist. Do not routinely offer lumbar puncture. And there was a this is a way. There is a place. DSA or MRI does not show aneurysm, and consider it. This is the if you think about another diagnosis. So if you diagnosis not a subarachnoid, so you have a lumbar puncture negative, and if you think about other diagnosis, then you don't see aneurysm, then that is an indication for MRI. So you have subarachnoid, but the patient suspecting subarachnoid, but you don't see aneurysm. Then you think about some other, like bleeding into the tumor, some other thing. Then you go for an MRI, say cavernomas or some other thing. And the other indication in if you have patient with aneurysm, we do annual or kind of MRI, especially in polycystic kidney disease patient. Polycystic kidney disease patient, we do non-invasive MRI test to see whether they are developing aneurysms. Because the advantage is the MRI is non-invasive. But if you're going to do CT angio or DSA, it involves the contrast.
Right. In the absence of any questions, I would like to thank Dr. Sanjeewa Garusinghe for accepting our invitation, and I'm sure our audience and college members have benefited vastly through this lecture. So I thank again Dr. Sanjeewa Garusinghe, and I thank President and Sri Lanka College of Internal Medicine Council for allowing to go ahead with this therapeutic forum. And lastly, but not least, I thank the audience for their generous participation. Thank you, Dr. Garusinghe.
Thank you very much, and thank you, Dr. Ranga, and thank you, Dr. Prashant, for giving this opportunity.
Good night, everybody. Thank you.
Good night. Right?
Thank you very much, Sanjeevan.
Thank you.